Well, once again, good afternoon, and thank everyone for joining us for this very special Talk with a Doc presented by the American Heart Association and Indiana University Health. My name is Dr. William Gill, and I have the pleasure to be associated with both of these very fine organizations. I'm a cardiologist and have been with IU Health now for more than 17 years. I'm also a member of the American Heart Association's Board of Directors in Indianapolis, recently having served as the Heart Association's board president. The American Heart Association has been very committed to fighting heart disease for nearly 100 years now. Every year they fund tens of millions of dollars of cutting edge research, advocate for health policy at all levels of government, and work directly in thousands of communities to help people live longer, healthier lives. IU Health is the largest network of physicians in the state of Indiana, offering care by more than 1,500 doctors at more than 200 locations. Today, we bring these two esteemed organizations together to provide you with information about heart health. This is very timely. February is American Heart Month, so this is the perfect time to speak about heart health. Even during these past 2 years of the COVID-19 pandemic, heart disease, unfortunately, has remained the leading cause of death in the United States. In Indiana, approximately 14,000 people die every year from heart disease. And that is actually enough people to fill Victory Field Baseball Stadium in Indianapolis every year. Thousands more experience heart attacks, heart failure, coronary heart disease events, and other heart problems. Because of its prevalence, heart disease is something that touches almost all of our lives in one way or another. But fortunately, the majority of heart attacks and many forms of heart disease are actually preventable. Many of the risk factors that lead to heart problems, such as high blood pressure, smoking, obesity, high cholesterol, and sedentary lifestyles, are things that we can impact by the decisions we make regarding our diet and activity levels. We're going to talk a lot more about that today. But it's also true that there are some things that we have little or no control over when it comes to heart disease and its risk factors. That includes our genetics, like our family history. And Dr. Julie Clary is going to share more about genetics with us this afternoon. We'll also be joined by Dr. Tamarappoo, and he will share some of the tools that doctors have to find and diagnose problems with the heart. Like many illnesses, the earlier something is diagnosed, the sooner treatment can be started to avoid bigger complications. Today, we're going to have plenty of time for your questions as well. We want this to be interactive ultimately. We want you to feel free to type those questions into the chat box at any time, and we're going to do our best to get to most or all of them if possible. I would encourage you to keep any questions of a general nature, though. We don't want to get into too many specifics with regard to your own personal health. At this time, I'm going to ask Dr. Julie Clary to kind of take over now. Dr. Clary is a cardiologist with IU Health. She is board certified in cardiology and internal medicine and is currently an assistant professor of clinical medicine with a focus on lipids and prevention of cardiovascular disease. And so at this time, I thank Dr. Clary for joining us, and I think you're really going to enjoy her presentation.
Thank you, Dr. Gill, for that very kind introduction, and thank you to the American Heart Association for putting together this presentation today. As Dr. Gill mentioned, I am a general cardiologist here at IU Health. I've had the pleasure of knowing Dr. Gill since I was a trainee many years ago and have been on the faculty for now about 7 years. My focus is on prevention, and I'm very passionate about this condition called familial hypercholesterolemia, which I like to abbreviate FH because it's a lot easier to say, but I'll be telling you all a little bit more about today. So just a quick survey. I know I can't really see responses, but if you'd like to drop it in the chat, that would be great. How many of you are familiar with familial hypercholesterolemia? Has anyone heard of it before? All right, I'm getting a lot of no's in the chat. Well, I've got one from Mike Wagner. I'm glad he's heard of it. So I'm happy to be able to tell you more about it. So FH is a genetic condition. There we go. FH is a genetic disorder that causes dangerously high levels of LDL, which is the bad cholesterol, from the time that you're born. It leads to early heart disease. People with FH can have heart attacks in their 20s or 30s, so at very young ages, and it's in their genes. It's just something that you're born with. It's also pretty common. It affects about 1 in 250 people. We all know more than 250 people, so chances are you probably know someone with this condition, whether or not they know they have it. It affects over 30 million people worldwide of all different races and ethnicities. As I mentioned, it's also underdiagnosed. So only about 10% of people with FH actually know they have it. That means 90% of people don't know they have it and are at risk. Unfortunately, FH is also serious. As I mentioned, it causes heart attacks at a young age. And about 1,750 people, which is the same number of people that die from car accidents every year, die from FH. About 800,000 Americans have a heart attack each year, and individuals with FH who are untreated have 20 times that risk. It's important to find, though, because it can be treated. We can diagnose you either clinically or with genetic testing. And as I mentioned, it's something that we can treat to prevent serious trouble down the road. So how do we diagnose it? As I mentioned, we need to get everyone's cholesterol checked. So kids should be getting their cholesterol checked between the ages of 9 and 11. Or if they have a family history of heart disease or high cholesterol, they should get their cholesterol checked at the age of 2. After that, at the age of 20, everyone should have a screening. And then every 5 years after that, if you're low risk. However, if you're higher risk, you may need to have your cholesterol checked every year. As I mentioned, it's treatable. We have great medical therapies that have really evolved over the last decades that can successfully treat FH, and with good lifestyle management, we can prevent heart disease. As I mentioned, the foundation is a heart-healthy lifestyle, and that'll be a theme across everything we talk about. Having a good foundation is important to prevent disease, no matter what your genetic makeup. However, these individuals that are afflicted with FH, diet and exercise aren't enough because it's a problem with how their body handles cholesterol itself. It's nothing that they do or don't do because of their diet and exercise patterns. But luckily, as I mentioned, we do have great therapies that can help reduce their risk for heart disease. And we can reduce that risk to nearly that of the general population. So here's maybe a typical family with FH. If a man has FH and is untreated, they have a 50% risk of having a heart attack before they turn 50. Whereas a woman who's untreated with FH has a 30% risk of having a heart attack by the age of 60. These are much higher than the general population. As I mentioned, if you have a family history, it's appropriate to treat children or to test children by the age of 2, and we can actually start treating kids with this condition between the ages of 8 and 10. So, in summary, how do we diagnose FH? If you have a family history of early heart disease, so that's a heart attack or stroke or problems with your arteries before the age of 55 in men or 65 in women, or if you personally have high cholesterol, that's an LDL above 190 or an LDL above 160 in children. So if you have these two things, you have the family history, you have the high cholesterol, the F and the H, it's possible that you could have familial hypercholesterolemia. And I'd encourage all of you to make sure you know your cholesterol levels, and if they're elevated, talk to your primary care doctor about learning more.
Julie, that's great. Thank you so much for that. I know we're going to have time for questions from folks, but I just wanted to ask one real quick now. This is a genetic disorder, and certainly medications and therapies have come so far just in the last 10 years, even for normalizing cholesterol levels in so many of these patients, just as long as we identify them accurately. Is there any hope for true genetic therapy for these individuals that you envision coming in your career or soon, perhaps?
That's certainly something that's being studied. That's a great question, Dr. Gill. And it's exciting to think that we may be able to alter the genome in these individuals that have a genetic variation that causes their disease. So yeah, there is CRISPR technology that's currently being studied. And maybe down the road, this will be something that's not just treatable, but curable. That would be very exciting.
That would be super. That'd be awesome. Yeah, I agree. Totally agree. You mentioned obviously lifestyle modifications as well. And one of the things that the American Heart Association speaks about is our Life's Simple Seven. Years ago, the American Diabetes Association spoke of kind of know your numbers as well. And I think you alluded to that here also. So many of us do not know our numbers, but I find that checking our blood pressure and knowing what our blood pressure is, knowing what our blood sugar is, and knowing what our cholesterol is, I think these are really essential vital signs, if you will, for us as we contemplate preventive heart therapy for ourselves as individuals. Regular exercise, complete abstinence from tobacco, and a healthful diet kind of round out the things that we think about as being incredibly important for helping to prevent heart disease going forward. And I think we're going to have ample opportunity to talk some more about all of that as we go on today. But without taking up too much more time right at this moment, I want to introduce Dr. Tamarappoo, who has a number of interesting things to share with us about various types of technologies now that we are using to assess heart disease. Dr. Tamarappoo is an associate professor of medicine with IU Health. He has a particular interest in advanced cardiovascular imaging. And so things that can be done today are really groundbreaking, in our opinion, as cardiologists, for helping us to identify heart disease early and intervene where appropriate as soon as possible. So Dr. Tamarappoo, I turn it over to you. Thank you.
Thank you, Dr. Gill, for the introduction. I'm Balaji Tamarappoo. I am a cardiologist with a lot of interest in training in cardiac imaging technologies. Most of you have probably heard of cardiac CT scanning and MRI imaging. So these are the two topics that I will be talking to you this afternoon. And the focus of my talk will be on atherosclerosis, or what we call cholesterol plaquing in a simple way, and also what we call microvascular dysfunction, which essentially means that there is some abnormality in the small, tiny blood vessels that provide blood supply to the heart muscle. And I will try to explain some of the scientific jargon to make it as simple as possible. Okay, so I apologize. So most of you have heard about echocardiography or cardiac ultrasound. Many of you might have heard about nuclear perfusion imaging or nuclear stress testing. Some of you might have even had some of these procedures. The new kids on the block are coronary CT angiography, or simply called cardiac CT, and cardiac magnetic resonance imaging, or CMR or CMRI. These two are relatively new technologies, and they are very powerful in allowing us to find out if a person has heart disease and also probe for potential reasons why the person has heart disease. And Dr. Clary talked about cholesterol and familial hyperlipidemia. So you can usually detect cholesterol with a lab test. You could try to look for genetic markers of familial hyperlipidemia. On the other hand, a more simple approach without the use of genetic testing will be to find out if you have plaque. So for example, if a patient comes to Dr. Clary's office and has a high cholesterol level and she suspects that this person has cholesterol deposition in their heart arteries, she would then turn around and send the patient to a cardiac CT scan. And this is a three-dimensional rendering of what a cardiac CT scan looks like, which is on the upper left-hand corner of this image. This is what we call an axial image. And then these are pictures of the coronary arteries in the two panels below, stretched out to show how the artery looks like in its entirety. So the very strength of this is that it can show you places where the artery might be narrowed with plaque in the vessel wall. So in addition to giving us details about the presence of cholesterol plaque, what we are now able to do, and this is more modern technology, if you look at the right-hand side of the screen, you will see these orange and yellow little areas. So this is actually the fat that surrounds the artery. So there's new data that's coming out showing that the fat that surrounds the artery is also highly inflammatory. So we can actually use CT scanning to measure how much fat a person has within the artery, which is this yellow area here, which shows us a calcified plaque. But we can also figure out how much fat there is surrounding the artery and the inflammatory potential for all of this. So the reason I'm showing you all these pictures is to let you know that, it's not only finding where the plaque is located, but actually going in and analyzing the plaque to give you more of a composition, because we know that the type of fat that is in the artery is a major determinant of bad things happening to patients. Here is an artery with an obstruction, and you can see the plaque. This is the place where the blood is flowing through the artery, so a large amount of the artery is covered in plaque. Interestingly, in women, ulceration is more common rather than just a breakage of the plaque. So in women, heart attacks can actually present without a complete blockage, but with just ulceration. So this leads me to the second part of the talk, which is how can we find out what is going on, especially in women where they have chest pain, where they have symptoms, but when you do cardiac CT scan, the artery does not look completely blocked. How do we address this? So this is where there is a big challenge because we are now going to address how to look at tiny blood vessels that provide blood supply to the heart muscle. So here's a pictorial representation. You can think of the artery as the main root of a tree, and then all the little tree roots coming off the main roots are these coronary microvascular structures. So cardiac MRI is a very powerful tool. Here are two images that I'm showing where you can actually see the blood flowing into the artery with cardiac MRI. I don't know why this bottom panel is not playing. Let me see if I can activate that. Okay, so you can see on the bottom panel, there is actually, and this is a rest and stress image. So during stress, there is a small area of the heart muscle that is not getting the contrast. And so that is shown here on this slide with the yellow arrows. That's the portion of the heart muscle, the very inner portion, which is not getting adequate blood supply. And so we can actually conclude from this that there is a defect in the blood circulation or perfusion in the tiny blood vessels providing blood supply to the heart arteries. So in summary, if you have a question for your doctor and you say, do I have plaque in my blood vessels? Your doctor is most likely going to order a coronary CT scan, usually a calcium scanning. But what I'm trying to convey to you is a coronary CT angiogram is a more powerful tool than just a coronary calcium scan. And we have that ability here at IU Health. If your question is, are my chest pain symptoms caused by plaque in those blood vessels? Once again, coronary CT angiograms can help you. However, if you get a coronary CT angiogram, there is some plaque, but it's not really causing a lot of obstruction, and you still are having a lot of chest pain symptoms, your doctor might then go on and recommend a cardiac MRI scan, which you can do with rest and stress to really bring out what might be going on in the very microscopic tiny blood vessels. Thank you once again for your attention and happy to answer any questions.
Dr. Tamarappoo, thank you so much. That was outstanding. And really it is cutting edge information that you're providing to all of us today. One of the questions that's been brought up Is there currently a recommendation for an age at which somebody should consider getting a quote unquote heart scan, looking for their coronary calcium score? Do you have a recommendation that you would make for people?
That is an excellent question, because it really comes down to the art of medicine, especially in cardiology. So the recommendations are usually restricted to what is called the gray zone, which is also called in scientific terms an intermediate likelihood of coronary artery disease. For example, if you have a 30-year-old male with no family history of coronary artery disease or heart attacks in his immediate family, he is not a smoker, exercises, is at a good weight, and is healthy, and the cholesterol levels are normal, I would not recommend a coronary calcium score. On the other hand, for example, if you were to take a 45-year-old male or a 40-year-old male, for example, slightly overweight, cholesterol is higher than the recommended values, say, for example, around 130 milligrams per deciliter of low-density cholesterol, and and has borderline blood pressures, that person, I think, would be a very suitable person to check a coronary calcium score, because that might allow you to embark on lipid-lowering therapies, like what Dr. Clary would normally do, or to add other medications and be more aggressive in the way you treat this person.
I think that's great. And in fact, at IU Health, I think that we have instituted policies not to do them, generally speaking, in individuals under 40. And in fact, if we look at all comers at age 40, even males at age 40, 80 to 85% of 40-year-old men have a calcium score still of 0. And so it's not a very distinguishing test at that point, unless you have a particularly high cholesterol or perhaps a significant or malignant family history of coronary disease, as you were kind of alluding to, for sure. So I think that's spot on as far as that goes. One other thing I would just bring up as well and ask you, Dr. Tamarappoo, for any comments you would make. I think many individuals in the community who are suspected of having heart disease, who may have chest discomfort, while some may actually get stress cardiac MRIs, as you suggested, is an option. Can you just say a word or two about other stress testing modalities? Because I think it's probably the experience of most that they're going to be referred by their doctors, reasonably appropriately, in fact, for other modalities for stress testing to investigate chest pain disorders and the like that.
Once again, great points that you make regarding the types of stress testing that are out there and who would normally get referred to stress testing. We now have some guidelines from the American College of Cardiology and the Heart Association recommending cardiac CT or coronary CT angiography as a first line. For example, if a person comes in with chest pain symptoms, does not have these elevated enzymes called troponins that are released during an active heart attack, cardiac CT is actually being recommended by the American College of Cardiology and Heart Association. A stress test would be more for somebody where you suspect there is some heart disease. They have already had a history of heart disease, but you're unsure of exactly what might be going on. Even among stress tests, the most common stress test is a nuclear stress test, which is available almost everywhere, I should say, is easy to perform, takes about a few hours, and is the most common modality. The issues with nuclear stress testing are that you can get a lot of false positives, meaning you may overestimate the presence of something significant because of body size. You can have issues with radiation, for example. So you really don't want to be doing a nuclear stress test every 3 or 4 years in somebody. And those are the advantages of a cardiac MRI. Of course, a cardiac MRI stress test is not available everywhere, and therefore that is a problem. However, we do not use radiation with MR studies, and we are able to do it within about 30 minutes, just a rest and a stress scan. And so if you look at a nuclear scan versus an MRI, I would probably choose that for patient comfort and how quick we can get it done.
That's great. Dr. Clary, I'm going to pull you back in for just a moment here for sure. A question that I had as we were talking about life's simple seven, blood pressure is one of those things that I sort of alluded to that we ought to be knowing our numbers. Can you make a comment about sort of why blood pressure is important for us and what's a normal range and how can we do things ourselves to keep blood pressure under control for ourselves?
Sure. So blood pressure is the force of blood pushing against the arteries with each beat of the heart. So when the heart squeezes, that's when the blood pressure is the highest, and that's the systolic blood pressure. That's the blood pressure you see listed on the top. Then the heart relaxes in between beats and the blood pressure falls. That's called your diastolic blood pressure. That's the number that's listed on the bottom. So we'd like to see those numbers less than 120/80 would be a healthy range. There's lots of things we can do to maintain a healthy blood pressure, many of which were listed in that simple seven. Get regular exercise. The recommendation is to get at least 150 minutes of aerobic exercise every week. You can slice and dice it however you'd like. You can do 30 minutes 5 days a week, 50 minutes 3 days a week, however you'd like. But try to get 150 minutes of aerobic exercise each week. That's great, not just for your blood pressure, but also for your cholesterol, your weight, your blood sugar, really just a heart-healthy lifestyle in general. Other things that you can do are to ensure that you eat a heart-healthy diet and really try to limit the amount of sodium that you take in to less than 2,000 milligrams per day. Another good way to manage your blood pressure is to also manage your stress, which is certainly easier said than done. But trying to practice mindfulness techniques and relaxation techniques can really affect your blood pressure as well. And avoiding smoking, very important. Smoking does elevate your blood pressure. So quitting smoking, if you are a smoker, can help control your blood pressure as well. One other thing, Dr. Gill, if you don't mind, that sometimes gets overlooked is sleep apnea. Many individuals might suffer from sleep apnea. They may know they have it, they may not, but untreated sleep apnea will also lead to high blood pressure.
That's great. That's great. Yeah, one of the things, just to kind of follow up even on your comment about sodium, because I have many of my patients probably on a weekly basis tell me that they don't salt their foods, but I confess to them that I am sure there's a salt shaker in my house, but I don't know where it is. Having said that, I think I probably also follow a high salt diet on a lot of weeks. And the salt is in the foods that we choose to eat, and it gets at us pretty quickly. So 2,000 milligrams of sodium is almost the equivalent of 2 slices of Papa John's pepperoni pizza. And so just as I share with my patients, the last time I had 2 slices of pepperoni pizza from Papa John's was just before I was thinking about eating the next 2 slices. And so I think that we can get a lot of sodium in our diet really quickly if we're not being careful. And so I just caution folks to kind of keep that in mind and be mindful of where the sodium is. Dr. Tamarappoo, I'm going to pull you back in too for a question. One of the things that we have been challenged with over these last couple of years during the COVID-19 pandemic is that many of us have been putting off getting routine or preventive care. I was wondering if you could just give us a little bit of insight into the value and importance of seeing your doctor on a regular basis and not putting off this important preventive care.
Once again, you make some very excellent points, and it actually hits home because, on a personal note, I had postponed seeing my primary care doctor because of all of these concerns about COVID. And when I walked into the clinic, I did find out that my blood pressure was higher than what I thought it normally would run. So, I think it is essential for all of us to not only monitor our own blood pressure, heart rate, the level of fitness, as Dr. Clary mentioned, which is extremely important for maintaining our heart rate and blood pressure at normal levels and also our cholesterol at normal levels. But I think visiting your primary care doctor, having your labs done on a regular basis, especially if you are over 40 or if you have a strong history of heart disease, those are, I think, important first steps. And it also allows your doctor to think about other tests if they become appropriate. Like I said, if you are a person with a high family history of heart disease, or for example, tobacco use, or a history of high blood pressure and obesity, these are all important concerns that we as physicians look at when we look at the entire picture and think of ordering, for example, a coronary calcium scan, or even, for example, a coronary CT angiogram, because we are now finding out in a study that we are conducting, well, it's a big effort by IU Health, looking at how heart disease presents in diabetic patients. We're discovering that patients who have no symptoms but have diabetes relatively well controlled, but risk factors for heart disease actually have plaque in their arteries, and the plaque can be quite extensive. So these are important considerations that come into the picture, which make me once again reinforce timely preventive care is an extremely important part of every patient's good health and well-being.
Thank you. I think we have a video even that can speak to this point still again. And so I would ask maybe if we can roll the video in order to kind of just share that with our audience now also.
It's not just saying I love you. It's not just a warm hug or a hand to hold. Loving my family means helping them get the care they need to control serious but manageable conditions like high blood pressure and diabetes, because acting now can help us have more healthy years together. My world is better with Mama, Pops, Auntie, and Tio. It's time we check up on our health and the health of those we love, because doctor, it's been too long.
And I think it may have been that way for so many of us right now. I don't know your situation, but if you put off any type of care over the last 18 to 24 months, even preventive visits and routine checkups, I would encourage you to make an appointment with your doctor now so you can talk about your health and risk factors for diseases like heart disease. This is best managed preventively, we believe, for sure. Well, listen, we have plenty of time still to get into some questions and answers, and a lot of folks have been sending in questions to us, and I want to make sure that we try to get to as many as possible. Doctors Clary and Tamarappoo have been trying to answer some of them in the sidebar as we go through. One question that was brought up that Dr. Tamarappoo has already addressed, and I'm just going to put my take on it as well. The $49 calcium score test, what we refer to as heart scan tests, is there value in these even when we have CTA, coronary angiography, CT angiography available to us today? And Dr. Tamarappoo very appropriately pointed out that for his symptomatic patients, those who are presenting to him with chest pain, tightness, pressure, shortness of breath, etc., these are individuals that probably require more direct imaging of the heart arteries themselves, such as can be done with a CT angiogram, or some sort of functional test, as we call them, which is a stress test. However, I think the heart scans have some value for sure for those individuals, not who are symptomatic, not who are currently limited or having chest pain symptoms, but rather for the asymptomatic individual who assumes probably that their heart arteries are good and they're doing well, but maybe harbors some genetic risk factors, family history of early or premature hardening of the arteries being that cholesterol plaque buildup in the heart arteries. Somebody who otherwise is really healthy and maybe has a borderline LDL or bad cholesterol level, and they wonder, is this bad cholesterol level resulting in accelerated plaque formation in my heart arteries or not? This is a place where the heart scan may help to better inform decision-making and may help tip the scales a little bit for us in regards to whom we may refer for further testing and specifically for further preventive treatment. So I just wanted to kind of throw that out there as well. Dr. Clary, one of the questions that came across to me was, how do our doctors know if our cholesterol is high because of genetics, or is it high because of our diet or exercise? What would you tell folks in that situation?
Yeah, so that's a great question. And sometimes it can be hard to tease out. So what we like to do is look at patterns of cholesterol over time. If you used to have very well-controlled cholesterol and then something changed, you became less active, you broke your foot and you couldn't exercise for 6 months, and you started eating poorly because you were on the couch all the time, and now all of a sudden your cholesterol is high. You may have a genetic predisposition for that because there's certainly individuals that do the same thing and won't see that rise, but they likely don't have a single gene cause for high cholesterol. The other thing we look at is family history. If we look at your family tree and we see that, you know, mom and grandma and 3 aunts and your cousin, you know, they all had heart attacks at a young age, probably related to your genes. And sometimes we don't know, and we say, you know, I'm not sure. And in those individuals, despite our best clinical assessment, then we do consider genetic testing. The genetic testing we do for familial hypercholesterolemia is very focused just on the 4 genes that cause familial hypercholesterolemia. So we don't return with a lot of extraneous results that are difficult to interpret. So we just look at those 4 genes that cause familial hypercholesterolemia and look for abnormalities there. And the genetic testing is good. It'll pick up about 80 to 90% of these cases. So if we're in that gray zone, genetic testing is a really nice option. That answer your question?
I think it does. Yeah, I think that that's great. And I agree. I mean, our genes and our diet obviously make up the pairing of our risk. And ultimately it's the number, it's the LDL cholesterol that's the problem. And sometimes we have to investigate that and get it treated. And we oftentimes, as you've pointed out before, we have to treat it on multiple levels. We have to treat it with diet and exercise. We have to treat it sometimes then also with medications. Dr. Tamarappoo, I'm going to flip it to you. There's a question about ulcers of cholesterol plaques in coronary arteries being more prevalent in women. Is this what women, or what we might refer to as a silent heart attack in women, or what kind of comment would you make about the differing pathophysiology for women's heart attacks versus men, perhaps?
So historical evidence tells us that a large number of women who have heart attacks don't have, for example, a breakage of a really large plaque, which then stops blood flow in the arteries. It's usually more of an ulceration where the blood within the artery gets in contact with the cholesterol particles and inflammatory particles that are in the plaque, and then sets off a cascade of plugging of the arteries, downstream plugging in the very tiny blood vessels, etc. Women also, for example, have microvascular dysfunction, or a greater number of women seem to have microvascular dysfunction, which is where the artery does not open up as well in response to a stressful situation. So this is why there's now been a lot of attention being paid to how do heart attacks present in women. There's a study called the Warrior Study, which is being run out of the University of Florida. And we at IU Health are actually participating in that study by analyzing the CT scans of women who enter this trial. And our goal is to really characterize how plaques are distributed in women. Do women have more plaques all throughout the arteries, which seems to be what we're finding. We also find that even for a given amount of plaque in the arteries, a woman has a higher chance of adverse cardiac events in the future. So for whatever reason, even a small amount of plaque in the arteries in females somehow causes worse outcomes. And what we're trying to do is also pick apart if certain medications should be used in these patients. So you're absolutely right. This presents as what we call silent heart attacks or silent ischemia, but is an area of great interest. And I think many of us at IU Health have the expertise and interest in pursuing this.
Thank you. Excellent. Dr. Clary, a question for you. Are there individuals, I know you mentioned that we may all be susceptible to risk for familial hyperlipidemia. It is found worldwide and is prevalent enough to be 1 in 200 to 1 in 300 individuals in the United States. But are there certain populations of individuals that are particularly susceptible or have a particular genetic predisposition for familial hyperlipidemia that you would really say you got to get checked?
I mean, I'm biased here because I think everyone should be checked. I think
Perfect
your
answer.
risk is high enough, no matter what your ethnicity is. Yes, there are some ethnicities that do have a higher baseline risk of familial hypercholesterolemia. That's true, but the risk is high in everyone. If your LDL cholesterol is above 190 and you have a family history of this, it's something you should consider. And as I mentioned, the reason is if you identify yourself as having familial hypercholesterolemia, that means that you have a 50% chance of passing it down to your kids. So maybe you don't get tested for yourself. You say, you know what? I have high cholesterol. Maybe I've unfortunately had a heart attack already. It doesn't matter if I have FH, right? I'm going to be treated the same. And that may be true. However, if you know that you have FH, you have a 50% chance of passing it on to your kids. There's a 50% chance your siblings have it. So if we can help to diagnose patients and then screen their family members, start their family members on treatment down to the age, again, between 8 and 11, we can reduce the risk of these individuals having heart attacks. And that's really what I'm passionate about doing.
I think that's great. That's great. And for sure, I could keep asking you questions about cholesterol, even for myself, to be perfectly honest. But I'm going to ask Dr. Tamarappoo to kind of make a comment about a question from Steve Banton. And he asks that he has heard that cardiologists all take statins prophylactically, keeping in mind that this is, heart disease is the #1 killer in America. And if we can prevent heart disease, coronary atherosclerotic events, and stroke in particular, by lowering our cholesterol, should we just all be taking a statin? What would you say to that, Dr. Tamarappoo? What do you tell your patients? You're muted right now.
See, I think he was on mute on purpose because he wanted me to answer that question. But we'll let Dr. Tamarappoo go ahead.
Well, I didn't want you guys to hear me laughing. Yes, do I think about this as a solution? Absolutely, because, I often wonder, would we benefit from driving our cholesterol levels to such low extent that we would have no risk of plaque formation at all? On the other hand, we know that atherosclerosis is, a genetic, there is a component of genetics which plays a role in it. There are environmental factors. There are also factors such as your diet, exercise, exposures. All of these things play a role. So it's difficult in medicine to really prescribe a drug all the way across the entire population. So to answer that question from this particular person, I would say, if your cholesterol is normal, if your heart rate is normal, your blood pressure is great, and you're exercising, you have a good body mass index, and you have no symptoms, I would shy away from using a cholesterol lowering drug because the side effects may actually be worse than your risk of having a heart attack. On the other hand, if you happen to get a coronary calcium scan and you realize that your total cholesterol is only 150 and your low density cholesterol is 60, which is the bad cholesterol, and your high density cholesterol is 50, which is a great number, yet you have plaque in the form of calcium in your arteries, then I would say you would be the perfect candidate for the use of a cholesterol lowering medicine despite normal lab values, because what it's telling us is that you somehow have a tendency to form plaque in the arteries and some kind of injury is occurring. So I would use a little more of a guided approach rather than just putting it in the water supply.
Perfect. And I agree completely. In full disclosure, I've been taking a statin since I've been 38. And so I'm one of those cardiologists that kind of almost put it in the water supply for me, but for very other reasons. And I've got some of those other risk factors. So I do this for what it's worth. But talk to your doctor. I find the statins to be As I tell my patient, they absolve us of sin, a little bit like holy water, absolve us of sin. Question for you, Julie.
Sorry, can I follow up?
Yeah,
that
please,
one
by
quick?
all means, yeah.
I mean, you can't let me not respond to that, right?
Absolutely, please, thank you.
So know your numbers, right? As we were talking about, you got to know your numbers. If you gave me a choice, either everyone gets treated with a statin or no one gets treated with a statin because we don't have any information, then yes, everyone gets a statin. But we're lucky enough to not live in that world, right? We can know our numbers, we can know our cholesterol, we can know our other risk factors. There's good risk calculators as well, right? We're our N of 1, as we talk about. We have our own single experiment with our bodies. However, we can use pooled data from studies that use tens of thousands of patients with similar characteristics, and we can put in our risk factors and calculate our risk and decide based on that risk whether or not a statin would benefit you. So I'll probably lose my lipidologist card for this, but no, I don't think we should put statins in the water. I think we should empower patients to know what's best for them.
Perfect. Hey, right back at you, Julie. A question was brought up by Jan Follett. We've talked a lot about LDL, or the quote unquote bad cholesterol, but I will tell you that in my patient population, one of the things that I remain challenged with is high triglycerides. Mm-hmm. And so, we appreciate that high triglycerides are sort of like, as I tell my patients, the free fat floating around in our blood. And they're certainly not good for us, but what can you tell us about risk, and what do we need to do about high triglycerides to modify cardiovascular risk?
Sure. So triglycerides, in recent years have really emerged as a cardiac risk factor. And now with some of the newer study data, we are targeting triglycerides in patients with heart disease. So we know that elevated triglycerides certainly contribute to atherosclerosis. The other sometimes more pressing concern of elevated triglycerides, or they can also cause something called pancreatitis, which is a painful, potentially life-threatening condition of inflammation of the pancreas, the organ across the top part of the stomach. Patients get severe abdominal pain, nausea, vomiting. It can really, really affect their life. So 2 reasons to treat high triglycerides. And how do we treat them? Well, I sound like a broken record sometimes. Lifestyle is the foundation for triglycerides. Sometimes more so than LDL, triglycerides are profoundly affected by lifestyle. And we know that triglycerides are also influenced by control of diabetes. So patients with uncontrolled diabetes with blood sugars that are significantly elevated will have high triglycerides as well. So I encourage my patients with high triglycerides to exercise, to eat healthy. I go through a low triglyceride diet with them, and also limit their alcohol intake. Alcohol raises triglycerides as well. There are some genetic causes, pure genetic causes of high triglycerides, but the majority of what we see is what's called polygenic risk. It's just a bunch of little things that are contributing in the background of lifestyle that lead to high triglycerides.
That's great. And a question for you, and this is something that Dr. Tamarappoo has already kind of touched on, but I'll ask you your opinion on the imaging. A couple of individuals have sort of chimed in, what's your recommendation for the use of heart scanning in an otherwise presumably asymptomatic individual? How do you use that information beyond knowing your numbers, for example, for your patients?
So thanks for bringing that back to me, because that was something I did want to touch on. And I think this is really important. I hope everyone hears this part. If you have symptoms, if you have chest pain, if you have shortness of breath when you exercise, if you have symptoms, you should not get a heart scan. You should talk to your doctor about what testing is appropriate for you. A heart scan is not a substitute for other types of testing for your heart to see if you have a blockage. So I just want to make that very clear, because I always worry that patients are just going to go out on their own and get a $49 heart scan that doesn't look too bad and feel reassured that, the chest pain they're having isn't coming from your heart, because that's not always the case. As Dr. Tamarappoo so nicely showed us, not all plaques created equal, and not all plaque is picked up on a calcium scan. So how do I use calcium scans in my patients? I use it in patients to decide on therapy, if it will change how I treat them. So I do have some patients who come in whose cholesterol levels are high. Their LDL is higher than it should be. However, they're young, otherwise healthy, don't smoke, don't drink, or well, don't smoke, exercise, don't have other risk factors. And when I put their data into the calculator, it says, you know what, they're low risk or maybe intermediate risk. They don't need to be on a statin. But for those patients that run in that kind of intermediate risk range, a heart scan can really tip you one way or the other. If you get a heart scan back and your score is 0, meaning you don't have any calcified plaque in your arteries, your chances of having a heart attack in the next 5 years are very low. They're not 0, which is why it shouldn't be a substitute for other testing if you're having symptoms, but they're very low. And that then would sway me to say, you know what? Let's forego a statin. Let's keep monitoring your cholesterol. Let's keep working on your lifestyle, and we'll reevaluate this next year. But if you get that calcium scan back and it's elevated, well, that's something different than the calcium or the cholesterol that you have in your body is causing problems, and now is the time to start a statin. So that's how I use calcium scoring.
I think that's so helpful, and I really appreciate you emphasizing the symptom portion of it, because I think that's incredibly valuable. I see many patients who come to me having gotten heart scans, and they've had positive calcium scores, and really the first question I ask them is, why did you get this heart scan? And so often it is for that very reason, as you mentioned. Well, you know, my wife noted that I've been breathing harder, or I've clutched my chest, and I don't wish for the heart scan. It should not be a first test for the symptomatic under any circumstance, but rather some other testing needs to be done, and you need to talk to your doctor about it. But it's especially, I find it reasonably helpful to help guide therapy, as you pointed out, for others, especially those who may think that they're doing awesome. And then if they did a heart scan when they were 50 or 55 in particular and found out that they had an abundance of coronary calcifications, it may change what we assess their risk as being at that time. Another question, and Dr. Tamarappoo, I'll throw this one to you. Without getting into too many specifics, maybe, how do we decide if chest pain that we're having is the kind of chest pain that we really ought to be alarmed at or go to the emergency room for? Or can we be reassured that there are certain forms or characteristics of chest pain that are more typical of acid indigestion or pleuritic type chest pain and things like that? Can you make a comment about that?
Okay, so once again, you know, I'm going to echo Dr. Clary's point, which is if you are having symptoms, and especially these symptoms are something that you have been observing as new and different than how you normally feel, you really should be consulting with a physician, because once again, there are many forms in which heart attacks can present. Having said that, you know, our historical and observational and clinical knowledge tells us that most patients who present with cardiac chest pain, in men especially, it presents with chest pressure, chest tightness, what we call mid-substernal pain, which is in the middle of the chest, radiation to the jaw or neck, radiation to the arms, especially the left arm. All of these kinds of things are associated with cardiac chest pain. On the other hand, if you are having symptoms such as shortness of breath that you observe is new and was never present before, that I think warrants absolute medical attention. You also need to realize that, for example, once you start working out or exercising, any change in how you feel might actually be a cardiac symptom. So, you know, there are very few things that I would sort of dismiss. If, you know, you've had these aches and pains for a long time and you've had a stress test, you've had a coronary calcium scan, and these things are a chronic nature and, you know, heart disease has been ruled out, I would feel relatively comfortable. In women, because we talked about this before, studies show that in women, chest pain doesn't present in the same way as it does in men. Women have more prodromal symptoms. For example, they may have lightheadedness, fatigue, weakness. All of these one would most often not think of as the result of a heart attack, for example, if it was in a man, but I would be very concerned. Extreme sweating, changes with stress, all of these symptoms are suggestive of cardiac chest pain. So the short answer would be if you do have chest pressure or tightness or difficulties with exercise, definitely go see a physician, because this might be the first sign that you have heart disease.
I think that's excellent. That's really great. And, you know, I can't believe it, but our hour is almost up. There was one other question that I have before me, and Linda Ellis asks, you know, how do we get this information into the communities that are most affected by heart disease? And I'm going to tackle that one. I think the American Heart Association is working hard at making that happen right now, right here today. We are getting information out to folks. The American Heart Association has online resources that are available to us that we can kind of Google search and look up and find out about healthful habits, heart healthy diets, regular exercise programs, and to understand life's simple 7. So I want to encourage everybody to kind of consider that and to get more information through the American Heart Association, who frankly is kind of getting the word out for all of us here in the United States. We're at the end of our time. Dr. Clary, Dr. Tamarappoo, thank you so much. I really appreciate all the wisdom that you've shared with us today. I want to especially thank IU Health for sponsoring this Talk with a Doc program. And I want to thank all of you, of course, for joining us. I appreciate your interest in heart health. And I want you to go out and share the information you learned today with your friends and family. This particular webinar will be recorded and put out for others to see at later days. And so come back to it, look at it again, and look forward to the next time that we have an opportunity to do a Talk with the Doc. Thank you guys so much, and have a great afternoon and a fantastic Heart Month.